All right, our next speaker received his undergraduate education at the University of Houston and received his postgraduate education at the University of Texas Dental School in Houston in 1975. He became a diplomat with the AADSM in 1999 and is presently an adjunct assistant clinical professor at Texas A&M School of Medicine. All right, in 1972, he joined the United States Naval Reserve, and upon graduation, he served in the United States Naval Dental Corps with the 3rd Marine Division at Camp Pendleton, California, and in Okinawa, Japan. His battalion was the spearhead for Operation Paul Bunyan in Korea in 1976. All right, he has been in private practice since 1976, practicing comprehensive and cosmetic dentistry, but for the last 9 years of his practice has been pretty much devoted strictly to sleep, right? Okay. He's a past board director of the AADSM and has lectured and published nationally, regionally, and locally, along with product development. He's also the founder of Breathe Better America and the Texas Dental Sleep Service. Dr. Martin Denbar.
Thank you. I'm supposed to read this disclaimer. I do not have any financial interest of a product or my talk with any companies offering grant monies for this continuing dental and medical educational program. So let's get started. I'm excited and honored to be here. How many of y'all are practicing dental sleep medicine in your practice? How many have ever utilized combination therapy with an interface? Have you been doing it very much as far as with severe cases? What we're going to go over today really is, I started doing combination therapy with an interface back in 2002. And I brought the field of dental sleep medicine to Central Texas in 1995. So I've been doing it for 27 years, over 5,000 cases. I treat very severe cases, as you'll see, with Lou Gehrig's disease, Huntington's chorea, Parkinson's disease, AHI is over 100, low oxygen levels down under the 40% range with and without teeth. And to me, it's exciting because it's really life-changing, and it's something, if you're going to do dental sleep medicine, you should have this capability. In my office, I have 10 CPAP units, auto units, they're Respironics, and I've got 16 wrist oximeters. I utilize for combination therapy the CPAPs as loaners for patients. I have all the software, and that way I can really be a mother hen watching over the cases as I'm doing it. So, conflict of interest, Texas Dental Sleep Services, founder of Breathe Better America. It's not going to impact anything we're doing here, so I don't need to go into that. Disclaimer, these are my opinions, and this is a relatively new field with very few high-level studies. Of all the articles published, I've got about 10 to 15% of them. My initial thoughts on this is you're really part of the physician's medical team. We have to stay within our scope of practice. And the head of the team is the physician and the provider of record. You're really working under his license. What I'm finding is a lot of dentists think that they're kind of overstepping their bounds. And like one friend of mine who's an attorney, who's also a dentist who does dental sleep medicine, a lot of this hasn't been really determined in the courts yet. So you've got to be very careful with what you're doing and work as part of a team. Combination therapy, you're usually going to be dealing with people with extensive medical comorbidities. So these aren't your typical patients. And mind you, we're not physicians, we're dentists. We have not had an internal medicine rotation. Unfortunately, I'll hear dentists say all the time, particularly at the local meetings, well, I know more than that, doctor. And I'm going, great. Well, what are you going to do with all the comorbidities? Because the head is connected to, the head bone's connected to the neck bone. I look at this whenever I treat as if, and when I document, as if I'm sitting on a witness stand. Patients that are chronically sleepy are different, it's a different group. Richard told me I could tell you this tale, okay? And the whole point with this is the chronically tired patients, you have to document. I had a lady in her mid-30s. She's sitting there, I'm doing the exam, and I told my assistant, generalized cervical erosion, right? Lady looks up at me and she goes, you can see my cervix from up there? And I said, no, ma'am, I can't. So I go home and told my wife. She goes, thank God you said that, honey. You had a guy coming up there with a shotgun. So the point being is that these people, you have to document. I'll just leave it at that. This is a typical case that I'll see. Now, I know all y'all would just love seeing someone like this walk into the office, right? And if you'll notice, the auricular portions were rejected. So I'll go over this case presentation. What was interesting is on the upper 4-unit bridge, when we did an algid impression, we took the bridge out with the teeth. So your typical dentist would not tackle something like this, but this is what we can provide and assist the medical community with. So when we're looking at this, all right, the classifications of sleep apnea, I'm in the middle of a move. That's why I flew out here to speak and I have to leave. So I'm trying not to be a little discombobulated, but I've been doing 15-hour days with moving. So this is really a great article in the sense that it said patients with mild to moderate sleep apnea with one night of portable testing can lead to a misclassification. I'll always have patients come in and they'll go, well, I had a home sleep test and it said only I had mild. Well, I've got documented cases where a patient one night they'll have an AHI of 2 and the next night 11, or the next night 11 and the next night 44. Night to night variability. You've always got to realize it's one night out of a patient's life. Could be the best, the worst. It is a snapshot. And with age, everything drops, airway lengthens, your apnea is going to get worse. And half my practice is skinny. I mean, it's crazy. I'll have, I got one patient, 6'4", 165 pounds. He's got an HI in the 20s. So much of it is specific to the patient, not so much figuring you're only going to be seeing obese people. This is what's interesting. I love this study in the sense that I'll have someone come with an AHI of 5, but a low SAT of 60%. And I'll have, on the sleep study, the physician will write mild sleep apnea. And I'm going, Lord, no, that's not mild. And so the thing is that you have to be able to work with the physician, interpret what's there, and realize it's just not a numbers game. Oh, he's got an AHI of this. And really, in reality, an AHI is not as accurate as an RDI. All right, the RERAs make a difference. And you will find patients who have severe apnea and show no symptoms, and you'll have patients who have mild apnea who are basket cases. Actually had one patient fall asleep pulling into the parking lot of his physician's office. He fell asleep when he turned in the driveway, ran right into the building. This was interesting for medical protective. This many doctors don't cooperate. I send a very professional letter out to the dentist because I believe in interdisciplinary therapy. I don't do any dentistry at all. And it says, this is what we're doing. If you have to do a filling or a crown, here's how you do it. And if you have a question, here's my phone number. But if you mess with it, you're going to own it, all right? And I've actually had some dentists write me back or call me and say, don't ever tell me what to do in my office. I'll do it in the hell I want. And I go, well, we're never seeing you again. And I tell the patient very nicely, and I've only had one stay with his dentist. I can't work with him. We all have to swim in the same stream surrounding you to take care of you. And if someone wants to swim upstream, my life's too short for that. We're here to work as a team. The biggest issue here is occlusion. In dentistry, the statue of occlusion is there and all the dentists bow to it. I'm very simple-minded in my old age. I asked patients 2 questions. Can you eat what you want? Have you missed a meal? No. Well, your bite works. Okay? And if their life is good, I had a gentleman who's age 55. This was last summer. He's in bed with his wife. He eats what he wants. He's on cloud 9. The guy, I mean, he's happy. I'm his savior. He goes to his dentist. Dentist walks in during the hygiene appointment and goes, oh my God, what did he do to your bite? You may need Invisalign. All right, so the patient comes back to me really upset and he goes, well, what do you think, doc? And I said, well, my truck's paid for, maybe his isn't. And I left it at that. And the guy walked out and said, fine. We have to treat. Another patient had a great term he coined. He said, I don't want to have the best bite in the cemetery. And really what we're looking at here is life and death, because I look at it in a different perspective. I had one patient who thought all this was a bunch of baloney. He didn't wear his appliance one night. At age 49, he died in his sleep. Coroner's report was apnea. I've had an EMS in my office with a stroke going on. I've had 2 patients, one not wear CPAP and one not wearing an oral appliance, and they're learning how to walk and talk again. So I take this very serious. And yes, it is compromised therapy. What is combination therapy? It's really when we're using 2 modalities. And in this case, an adjustable mandibular advancement device you can wear with a CPAP. But when you're sent patients, they don't want to wear CPAP. So by just adding more stuff on their face, it's kind of counterproductive. A monoblock is a guess. The whole concept with combination therapy is to adjust the jaw position such that you've reduced air pressures, you've increased, and you've gotten efficacious therapy. All right, so we don't have to advance the jaw as much, and at the same time, since we don't have to have the higher pressures to blow the air out of the way, blow the tongue out of the way, you're reducing pressures by about 30 to 50%. Let's see. This is exactly what I was talking to you about. By pulling the jaw forward, we're pulling the tongue out of the way. Now, there are different samples. I use a TAP-app interface. I've probably done 4,000, 5,000 plus TAP appliances. I love them. I was one of 5 offices in the US that used to manufacture them in-house. We had 24-hour turnaround time until one of the other offices had a patient break a piece and swallow it, and the physician said, I need to call the FDA immediately. So then they shut it down except for big commercial labs. So the point is that I love this. I take them apart and put them back together in my office. So to me, this is really the creme de la creme as far as interfaces is concerned. The CPAP Pro, I have a bunch of samples in the office I've never used because it's too bulky. And I do wear, I practice what I preach. I wear the TAP-app interface myself. The Fusion mask is great. Ron Pring has the patent, or not the patent, but he used to be the distributor for it. I've just never had to have an issue with that. I've had patients with pressures up into the high 20s where we were able to control with the chairside unit. And the Oventus is really interesting to me. This is going against everything that all the previous lectures were talking about. It's just blowing air in the mouth. You're bypassing the nasopharyngeal complex. We're no longer nasal breathing. So yeah, I mean, I'm sure it'll work, but you're basically creating a mouth breather. These are some of the studies that are out there, and basically everyone can look them up on their own, but I would put this with it. El back in 2011 showed that, and this is with a no interface used, just putting CPAP on top of an oral appliance, and it was only with 10 patients. The difference in the AHI went from 11 to 3, pressure reduction from 9 to 7. With this was another one. This was an editorial which was excellent, where it said basically it's an undervalued and underestimated service. And so it's something that, once again, the general dentist should be able to do this without an issue, but you do need to get some degree of training with it. In India, AHI of 66, they went down to 1.5. This is what I see in my practice many times. And what's interesting is that sometimes you'll find, when I'm talking, I may go to cover other slides ahead of time, so if that happens, that happens. But it's like when I was in the service, when I was with the Marines as the Navy, as a battalion dentist, I was going to be the forward triage officer to see who lived and who died in Korea if things started flying around. So to me, I look at myself as being a triage person. I'm triaging that patient. So a lot of times you'll get a real good AHI, but the oxygen saturations, or CT90, cumulative time under 90%, is still low. And you can't look at symptoms and look at the numbers. I'll have someone come in with a CT90 of 30 or 40%, and they think I walk on water. And of course you're going, wait a minute, that's not normal. And so on some patients, we'll actually have them, I'll send them back to the pulmonologist, the physician, they'll put them on ancillary oxygen through the CPAP machine. This was, I don't know where this study came from, where it says I've never had a case of this since 2002 when I started doing this in hundreds of cases where they're saying there's no difference. But once again, this was their results, and I'm presenting everything. John White did this study, which was excellent, 10 patients. AHI went from 66 to 4.4. Most physicians have no clue about this type of therapy. That's why we're so important for the dentist to be able to bring something to them about this. But he did an excellent study with this. This one here, one patient, no CPAP, validates what we're talking about here again. Keith Thornton, he was my mentor. This was his back in 2002. In fact, he published the first article. I think I was second by a few months. It was kind of interesting with that. This was the case that I went ahead and did in 2002. This was an engineer. And with the appliance alone, we got his AHI from 85 to 40. So what he did was he went in the garage and he made his own interface. And this is the interface. And with that, we were able to take him down to 7. Now, what's interesting, if you look at the PAP chair side, I'm not an engineer, but gosh, it sure does look an awful lot like what this guy developed in his garage on his own. This is another, El Sol came up with this, 10 patients. Once again, it's validating the service. This was an interesting case that I had. This gentleman was going to be the adjutant commanding officer for combat engineers in Afghanistan. And if you look at the timeline here, he had an AHI of 85. He was on CPAP for a certain period of time. They got him down to 6.2. Then they had him on BiPAP, took care of it. Then he came back to 19.5. He was non-deployable. But look at his central index at 26. So when we put him on a CPAP with the combination therapy with the interface, we were able to get his AHI to 0 and his central index to 0. But then when he went overseas, he was tested and his AHI went up to 19.5, but it was all negligible. In essence, with an oral appliance, what we're doing is we're taking apneic events, turning them into hypopneic events, keeping the saturation in the 90% range, and making sure that none of the saturations cause any sleep fragmentation. So if I get a patient whose CT90 is 99.9%, their AHI is fine, but it could be upper air resistance, they're doing a lot of hiccuping in the 90% range. But so long as it doesn't disturb them, is it ideal? No, but if that's the best you can walk away with, then yes, you take it. This was, you notice how the picture on the right here, the full dentition. Now, generally they would tell you you can't treat those cases, or you have to do 4 implants. I developed a technique where we can go ahead and treat these cases without implants. And it's rather easy, and I'll just kind of tell you, that it's in the Journal of Dental Sleep Medicine, I think it's January of 2017. When you're doing an upper and lower denture, you want to maintain a freeway space, correct? Because at rest vertical, you don't want pressure on the arches. What you do with this is that you go ahead and remove the freeway space, not to where you have them elevated, but the fact that their rest vertical is at the same without freeway space. So that way they have a subtle upper and lower pressure at all times. Yes, you need to use denture adhesive, all right? And you probably can't bring them out any farther than end-on position, at which time you put an interface on them, you see? But I can charge $5,000 for that, but go put in 2 or 4 implants, what's that gonna run? And the beauty is if you use the IVACAP injection technique, there's virtually no distortion whatsoever. And if at a later date you want to use a male-female attachment, you're quite capable of doing it. The other aspect is, since you're just transferring the hardware from the tap into the denture aspect, you can do a hard reline, a chair side, you can do soft relines. Even on this case here, these are actual cases of mine. Like with that, the patient with resorption over time, you can go ahead and do chair side or even send it into the lab to have it relined, which is really advantageous for the patient. Ron Preen did an excellent study with 75 patients, and in essence, it really validated exactly what I'm doing, or I validated what he's doing. You're getting about a 78% in the study through the University of North Carolina. I'm not sure if I skipped that one or not. I did a study through the University of North Carolina where we had, I think it was 70 or 80 patients. I worked with 4 doctors that had extensive experience with this. And overall, we got about a 67% recidivism rate for patients that were uncontrollable. In my office, we had an 80.1% success rate. And to me, if you can get an 80% success rate in anything with medicine, you're doing pretty good. Now, this was using the OVent 2. Once again, they had an improvement with things, but to me, when you're blowing air through the mouth, bypassing the nasal sinuses, I don't agree with that. This was a newer study. When they were picking 75% maximum protrusion, it showed additive effects. This is where an adjustable appliance really comes in handy. To me, you don't just go, I'm going to go 75%. I have found through thousands of patients that the most therapeutic position is going to be very close to maximum active protrusion and or slightly into passive protrusion. Maximum active protrusion, stick your lower jaw out as far as it'll go. That's maximum active, and or slightly beyond that, passive. When I take a bite, there are courses on how to take a bite. To me, I guess I've been doing it wrong for the last 27 years. My bite, what is the only one reproducible position in the mouth, unless you're a severe class 3? It's an end-on position, tip to tip, okay? A tap will go 6 millimeters forward. I'll just have them push their jaw forward. I can measure when, I've been doing it so long, if you haven't, you can take a millimeter ruler. If you have 4 millimeters protrusion and that's it, great, you got 2 millimeters for passive protrusion, okay? So the point is, I'd virtually always, unless I've got some patients that are very flexible. I actually had one, I have a private seminar in my office. I had one gentleman from Dallas come in, he couldn't believe it. I had one patient protruded 1.5 inches before we got his oximetry testing normal. The guy's flexible. I mean, the young dentist that was taking my seminar pulled his camera out. He couldn't believe it. But the patient had been with me for 20 years, flexible as can be, and that's what it took. So the point being is, everybody's different, but I have found after thousands of cases that that's going to be your therapeutic position in that range. Disconnected and connected, lower the frequencies. Like I said, I apologize. I've been running crazy myself with things. This is in essence, this is going to be another good one. Or this one here, yes, Mike Adami did it. I don't understand where they're saying there's no difference between wearing the device, wearing combo therapy with an appliance, CPAP with an appliance, CPAP with an interface and appliance. Anecdotally, I get a lot better results, fewer leaks, more comfort. Because see, what I'll do is if you go online, you'll find a CPAP holder. It comes in 3 pieces. And I give that to a patient. And you have that CPAP holder directly behind their head. The reason is that when they roll over, if it's on the side like the picture shows to use it, you'll roll yourself up in the hose. I've done that. So keep the CPAP holder behind the patient, and when you're doing that, you get 1, better results, 2, you don't get any pulling from the mask. And the biggest issue with CPAP intolerance is the air leakage. Okay, so whether you're wearing it with or without, with the interface you have less material on the head. Nothing's touching you but 2 silicone, very soft pieces in the nostrils. When you're wearing it with the headgear, et cetera, it's a whole different ballgame. So the factors that are going to impact combination therapy is resting tongue position. Now everybody knows where the tongue belongs, right? It's on the so-called spot according to Joy Muller. Put your tongue behind your upper 2 front teeth, 8 and 9, right between the first and second rugae, gently. Then lay the rest of your tongue at the top of your mouth. That's a normal tongue position. Virtually nobody has it, at least the ones that come in my office. So 1, resting tongue position is important, because when you realize that if your tongue is low in the mouth, it's down and posterior in your airway, right? And this is something, all right, I'm going to tell you, this is a test that I learned. Everybody know what a side plumb line is? I didn't. Side plumb line is you want to draw a line through the eustachian tube, through the center of the chromium process, to the floor. Your head should be centered over the body. Your head weighs 10 to 12 pounds. For every inch forward of your head's going to increase in weight by about 10 pounds. So what happens is if you have a low tongue level, your tongue is down and back in the airway. So a simple test that I have patients who think I'm full of baloney at times, I'll say, well, here, let's do a little test. So I'll ask them to stand up, and I'll ask them to move their head straight back, keeping their chin level with the floor, okay? And they'll say it's a little more difficult to breathe. Then I'll have them go back to normal, put their tongue where it should be, have them bring their head back, and there's no change in airway. It really blows a lot of people's minds. So now basically by looking at the side plumb line, now if someone has arthritic issues in the neck, that's one thing. But if they don't, by seeing a forward head position, you're going to know they have it where their tongue level is. Because a forward head position is a compensatory mechanism for a low tongue level in essence. All right? Whether a person's tongue-tied, everybody know what a reverse swallow pattern is. The normal swallow pattern, the tongue goes up behind your upper front teeth, touches gently, your teeth gently touch, and your tongue moves back in a peristaltic movement. When you see someone with a low tongue level, the tongue goes up part way, tongue goes between the teeth, and they got a little grimace right in here. That's a swallowing grimace. Now, when you're doing combo therapy and a patient's had a layup, the issue with combination therapy is you're blowing air through the nose. It's going to go back through the airway. It's going to push the soft palate up against the posterior area of the tongue. That's your first seal. When a person's had a layup, they're missing that seal. The second seal is bring your jaw forward, and at what point does your tongue go up behind your upper front teeth? That's your second seal. So just by having the patient move their jaw forward, some will say, well, my tongue never touches the upper teeth. Then they actually stopped making the lip guards, but I contacted Airway Management. They're now making them again. You may need to put a lip guard. It's just a little soft piece of silicone over the mouth to create a lip seal for the patient. But layups, UPPP, uveilectomies, and nasal patency can impact therapy. Everybody here familiar with Buteyko breathing? All right, well, you got to breathe through your nose. Y'all may know this test, I'm not sure, but it freaks patients out when they say, anybody here stuffy right now? Okay, a simple way to clear nasal sinuses real quick is simply relax, close your lips, and breathe through your nose. At the end of your next exhale, just hold your nose shut. Keep the lips shut. Move your head side to side. That's strictly for distraction. You could walk in a circle until you feel a medium sensation to breathe in the belly. Then when you do, keeping the lips shut, breathe back in. You a little clear? It may take 2 or 3 times, but I'll clear people up. I normally have them do that before they go to bed. It's real simple. I have a friend of mine who's boarded ENT, head and neck surgeon, board eligible sleep and allergy, and he was telling me in the sinuses, nitric oxide is a vasodilator, and of course it's made in the sinus linings. And the lining is very reactive tissue, like erectile tissue. And so what happens is when you're mouth breathing, you're bypassing the sinus, and nitric oxide is accumulating in the sinus itself. So when you just breathed in, you're pulling the nitric oxide out through the ostium, and that tissue contracts. So you'll clear people up. I've had people haven't been able to breathe through their nose in years. And it's a great second opinion when an ENT wants to do nasal surgery because they're always stuffy. And I go, here, do this exercise. And they go, well, I can breathe great. And I'm going, well, I don't guess you need surgery, do you? And then if they can't breathe great, then you go, hey, this is something you need to do. So it's just a real simple exercise. So the benefits of what we're really dealing with here is we're reducing pressures 25 to 50%. I use combo therapy. My normal pressures are 13 with just on its own. With the interface, they're 8 to 9.5. You don't get hardly any leaks, okay? I mean, literally, most of my cases are 0, maybe 1%. There's no restraining. You have full freedom of movement. I'm a stomach sleeper. You have stomach, side. I can hang you from the ceiling. It doesn't matter. It's attached to the appliance. And it can be modified to fit the patient's needs. What I've done is you'll find some patients, particularly females, that have sensitive scalps. So when they put the headgear on for CPAP, it's uncomfortable. What I did here with this case was I went ahead, got rid of the lower unit. They could use CPAP, don't get me wrong. I went ahead and used fast set acrylic. I think the younger dentists don't know what jet acrylic is from talking with a number of them. I'll put it on there. I'll just have them simply bite and centric. And then I'll go ahead and take it to the lab. You can see that I've got nice, uniform, mild cuspid rise, and it's a carrier. There's nothing touching their head, and they're very happy with it. So it's really just kind of a modification for doing things. So who should be performing this? I know there have been some physicians in the past who are doing MyTap, or I believe it's a Somnodent prefab appliance. When you read the research, the last time I read it, there's nothing that goes beyond 6 months with any kind of a prefab appliance that's worth a darn that works. So physicians have no business doing this, just like dentists have no business doing certain things physicians do. You need to be knowledgeable about what you're doing with this. Now, I trained myself because back then in 1995, 99, nobody knew what was going on anyway. You have to monitor. My protocol with patients is I'll go ahead and I'll seat the appliance or modify their appliance. I set up an appointment for an hour. The one difference with the sleep practice versus a dental practice, in dentistry you want to clear chairs, okay? I'm going to do the crown, then you get someone else in, correct? You know, it's restorative. With sleep, you can't do that. Usually things are going to start to bother a patient 10 to 15 to 20 minutes into their night. Then they're going to call you a few names and you get a phone call the next day. So like when I'm doing this, I set up an hour appointment. If I'm doing a delivery, it's an hour and a half to an hour and 45. I'll let them lay in the chair for 15, 20 minutes. Let them fall asleep. I don't care, because it's better that than getting a phone call the next day. So it's a different concept. You're not, if I deliver an appliance, I let them lay down for 15 minutes at the delivery appointment, and some will fall asleep. Right off the bat, you know whether they're going to be snoring or not. But still, you've got to realize who you're dealing with, and therefore you have to take your time to that extent. So when I'm doing a combo therapy, we'll seat it on day one today. I'll see him the next day or within a day or so for a first download, have him bring everything in the office, make sure that everything is fitting right. Some of the biggest challenges are with elderly. Of course, I guess I'm elderly now. And then what I'll do is I'll see him 10 days later for a second download. Then I'll see him 10 days later for a third download. And then depending on whether that one's good or not, I'll see him 10 days later and do an oximeter test. About 2014, I wasn't doing any oximeter testing. I'd get a great AHI. I thought I was wonderful. And then on several cases, we had great AHIs, but once again, their CT90s were at 70, 80, 60, 90%. And I started realizing that we needed to do oximetry with it, and some of them were on ancillary oxygen. And so I started calling the physicians saying, this is how we're going to do it. And they were all taken back, really surprised of the difference of how we had to correlate both of them. So I'll do is high resolution pulse ox. I use Nonin 3150s, and I have the Profox program for my final, and then I send a progress note to the physician and let them deal with it however they want. So this is kind of what my protocol is on this. This was an interesting case, case number one. How many of you guys would want to tackle this sucker? All right, 68-year-old female, and she had a few challenges mentally too. Uncontrolled hypertension, fibromyalgia, thyroid disorder, severe apnea, claustrophobia. And when we're talking claustrophobia, we're talking claustrophobia. Significant nasal allergies, joint replacement, periodontal disease. I mean, and she's got severe disease. I mean, I don't see how anyone lives when they're at night at 55% oxygen. To me, they're a facultative anaerobe. But the point is, I just don't see how they're doing it. After treatment, we got her an HI of 2.8, which is pretty good. What was interesting with her case, though, was that we did the interface and she couldn't handle the nasal pillows. So we had her on nasal cushions. And with the nasal cushions, we were able to get her treated. When we first started with her, she had no mobility. She couldn't open, I think it was like 25 millimeters. And I used a simple trick that I learned in dental school. It's like when you're going to snap your fingers, put your finger in there and you slowly stretch. After 2 weeks, we were able to get enough space with movement in order to get impressions. And we were able to get her to move forward just far enough to where her tongue created a seal along with a soft palate. So she's fully controlled. She brings us cookies every time she comes in now. This was an interesting case. You notice a full dentition? This was an 85-year-old gentleman. This was kind of an interesting case here. Let me just make sure. Yeah. This gentleman, he was a father of a city councilman. And you can see he's got a extensive medical history. Well, his wife was so worried about him that she would stay up at night watching him and make sure he was okay. This is the appliance. This was using a tap tube, but you see how, and I removed this second bar. We don't make them anymore, but you remove that bar there. By Medicare guidelines, you have to have 2 bars. As soon as they came in, I removed it. But once again, this is using the Iowa cap injection technique. Well, we treated him, and when you're doing a denture, you have to develop posterior stops. Do you see how tall those stops are? So that his rest vertical is such that there is, his rest position, there's no rest vertical. Those posterior stops go in there so we have a nice 3-point contact. So every position he's moving in, he's in balanced occlusion. So it's all one unit with denture adhesive, and it worked. The problem was that his wife worried about him because he wasn't making noise, so she would sit up and watch him to make sure he was okay. He worried, there was a little mental issues there. He would worry about her sitting up watching him, so he would stay awake watching her. So he never got any sleep. They both stayed up all night watching each other. So then we said, well, then why don't you, but he would take a 6-hour nap during the day. But we never could get him to understand that you can wear it in your nap time. He goes, no, only at night. So it never worked because he wouldn't wear it during his nap time. He had a little dementia there. But it did work. I mean, we were successful with it. And this is the setup. This was with the old interface where it wasn't chair-side prefab. We used to go ahead and actually modify it and make it to fit the patient at the time. This was an interesting case here. HI, they spent 297 minutes below 90% oxygen and 45 minutes below 85%. That's not good. But once again, only an HI of 10. So what, he's mild, right? So we put him on combo therapy. And as you can see, we got him completely treated, second download. But these are just different cases. Once again, you have to really look into it to see how you're going to treat it, because otherwise, who was going to treat this patient? They'd already tried the best that they could. He was CPAP intolerant, refused to wear it, period. This was another individual. This was an interesting case on BiPAP pressures of 29/23, and even so with an AHI of 30. We put him on the interface, and as you can tell, 40-year-old gentleman. I mean, that's a pretty extensive medical history there. We got his AHI down to 4.3 with an average pressures of 8 from 29. Yes, he's my friend now. But these are just really, I mean, it really makes a difference when you're seeing patients like this. So really, this is something that I think is, if you're going to do dental sleep medicine, this is a segment that you should have in your office. Because otherwise, what are you going to do? You just can't, I'll see patients where they'll go to the dentist and they'll have got their HI down to 15. Well, that's not acceptable. That's still disease. Is it ideal? No, but it's like my patient said, he doesn't want to have the nicest teeth and bite in the cemetery. We've got to work with this to get the overall scenario taken care of, and then you maintain it. The biggest issue here that y'all have to realize is documentation. If you don't have an electronic medical record for dental sleep medicine, you get one. Okay, I just got away from being over with the state board. I turned in 200 pages of documentation for one case, and they dismissed it. There was no reason for it, but once again, I've had a lady that nobody could treat in San Antonio or Austin, came in combo therapy, we had her fully controlled. This is where you start dealing with the mental issues, and as dentists, we're not trained for it like physicians are dealing with those things. I had her fully controlled. She got on the ground, tried to kiss my feet. I wouldn't let her. And then 6 months later, she had complications. She goes to everybody but me. She was a Dr. Jekyll, Mr. Hyde, retired Army nurse. So she comes in, and I'm naive and stupid. I'm thinking, hey, we're here, we're going to get her taken care of. So she's sitting in the chair, and she had a tube of toothpaste in her hand, tearing it in half. I didn't notice that. My assistant did. So I went to grab the appliance, and she took a swing at me. And I just went, okay, Med, nice knowing you, wrote her a check, and pushed her out the door. But the point is that you've got to be ready for these types of patients, because we're not trained in dental school for these things. I had another guy come in, he's an elephant. Someone 6'4", 6'5", 400 pounds, that's a big man. His wife's sitting right there. He couldn't drive from Fredericksburg to Austin because he was too tired. He turned to my assistant and said, you're a blanking blanking, not real nice words, I won't say them. And so my assistant came to me and said, he just called me that. So I walked in and the guy rips his towel off, stands up with his fist clenched and goes, you got a problem? I said, I just want you to have a nice day. I didn't have an elephant gun. You know, I mean, literally. So the point is that it's they're different patients by and large. They're great to work with, but you've got to document and get that electronic medical record. Make sure you're always, you know, around. If you're a guy, I'm not allowed into a room with a female without my female assistant, because once again, you're not dealing with people that are totally there many times because they're chronically tired. Other than that, if you have any questions, I appreciate y'all putting up with me because I've been putting in 15-hour days moving. I appreciate your time.